people in this room can change the future, it is critically important that we achieve the simple goal of getting research funding roughly close to match the burden of the problem or the disease. It's about a $4 to $5 trillion problem. That's about 20% of GDP. It's the most important pandemic of our children. Thank you for your leadership. I don't think it ever would have gotten off the ground if it wouldn't have been for your support. Next slide. And thank you for making us laugh, letting us laugh, for being human, for really being funny. Next slide. So we're sort of on a mentorship theme. This is Dr. Stone, Denise and Tim Fabian at the Southern Surgical. Dr. Stone was a early mentor, if I have them correct. I think you said Dr. Freeark, Dr. Zollinger, and Dr. Stone were key mentors of yours as a young person. Next slide. So Dr. Fabian went to Grady in Atlanta to do his trauma fellowship, and this paper was done, this work was done at Grady Hospital in Atlanta when Dr. Fabian was a fellow there. This was presented at the American Surgical and published in the Annals in 1979. Just to put it in context of where I was about to start medical school at that time when this paper was published. And prior to this time, for those of us who take all this for granted, that the standard of care, the routine, was that anybody with any colon wound got a colostomy, was diverted. That was basically what we did. Anybody had a hole in the colon got a colostomy every single time. It was mandatory. Came from the experience of World War II in North Africa, then generalized to all US and British forces. And that was the way patients were managed. Next slide. So Doctors Stone and Fabian came up with this set of criteria, these 7 criteria, that if you met these criteria, if you were in shock, if you had excessive bleeding, if you had multiple organ systems involved, if there was contamination, if there was a delay in operation, or if the colon wound was so destructive to require resection, or there's a big abdominal wall defect, those patients all got a colostomy in this randomized trial. So those patients went directly to colostomy. Next slide. So a good risk patient, the good risk patient without those 7 criteria were randomized to either primary closure of the wound or colostomy. And you can see there were 67 in the closure group and 72 in the ostomy group. And you can see that the obligatory colostomy had far more firearm injuries, as you would expect. Next slide. And if you looked at infection within the peritoneal cavity, there was a significant difference in that the ostomy group had the randomized ostomy group compared to the randomized primary repair group had an increased rate of intraperitoneal infection. Next slide. And as you know, there was increased colostomy-related morbidity from having the ostomy itself in the randomized group, and obviously in the colostomy group as well. Next slide. And there was a significantly increased cost in the colostomy group compared to the primary care, compared to the primary repair group. And there was 1 death in the colostomy closure group. So there was another death related to the colostomy itself. Next slide. This paper revolutionized the treatment of colon wounds. Now, to be totally fair in context, there were groups who were starting to do this. But once there was really a randomized trial that compared apples to apples, it totally transformed care everywhere. Certainly did it at my institution. I was a resident at that time, and we memorized these 7 criteria. They were probably criteria that you had to know on the app site as well. But it's hard to overstate the power of this study in convincing people that, okay, we can actually close the wounds primarily. And this question, though, became, which has been still trying to be answered for 40 years, can all wounds be closed primarily, no matter how destructive or what's the case? So next slide. So for these destructive colon wounds, which of those 7 criteria were critical? And so by the time I came as a fellow in 1991, next slide, this was really the question for colon trauma in our group was, could all colon wounds be closed or not? So this came from a very logical, focused approach to addressing this question. It started with a couple of papers by Salem George. The first was the first 5-year experience retrospective after Dr. Fabian came from Atlanta. And it actually, the results looked good. And it sort of raised the question of, this should be prospectively evaluated. So the next paper was a prospective evaluation published in 1989 from Drs. George, Fabian, and colleagues, where they prospectively looked at that approach and concluded that nearly all penetrating colon wounds can be repaired primarily or with resection and anastomosis. So at the time I came in 1991, really we'd sort of adopted the hypothesis that all colon wounds can be either primarily repaired or repaired with resection and anastomosis. Drew Poirier did to me, an interesting paper looking at the missiles and adjuvant and identified that for the patients where the missile, the bullet, the ballistic fragment, whatever you want to call it, traverses the colon, there was an increased risk of infection around the bullet tract. And they basically recommended removing that at that time. I would add another reason to remove it now is lead toxicity is another reason to remove it now. Next slide. So I was sort of tasked with or voluntold to look at the resection and anastomosis group. So the most destructive colon wounds. And so we looked at that group. One of the great strengths of the Memphis team was, at least compared to my home institution, had a really strong medical records group who was really interested in research, and they would actually pull all this data. So we looked at all of those colon wounds using an unselected approach. And what we found was there was a 14% leak rate in the resection and anastomosis group in unselected patients. We worked from the hypothesis that what leads to early failures of anastomoses? Well, obviously a technical cause could be, but the common physiologic cause would be decreased perfusion to the anastomosis or not a good intact immune system. So we looked at the patients who either had massive transfusion or who had a significant medical problem, and that's where almost all the leaks were in that group of patients. So we started adopting that approach. What followed were a couple of papers from Drs. McGrath, Maxwell, and Weinberg, specifically looking at rectal wounds. And the approach to that, looking at those data, were that intraperitoneal rectal wounds could probably be treated just as if they were colon wounds. Those in the extraperitoneal segment, if it was in the upper 2/3, perhaps the wound could be identified and repaired. It was surgical judgment with respect to whether the patient needed to be diverted or not. And those in the distal segment were treated with fecal diversion without a presacral drain if you could get drainage, but if you couldn't, presacral drainage. Next slide. There's a paper by Hargraves which really looked at digital rectal exam and proctoscopy for rectal gunshot wounds. for rectal wounds. And the takeaway message was neither are 100% sensitive. So neither are 100% sensitive. So clinical judgment's required in the, and just because it's negative doesn't mean the patient doesn't need to be explored. Then a series of paper from Sharp and colleagues really honed down and clarified the simple algorithm and looked at it in a wide variety of patients, in both blunt penetrating trauma patients and in those who were treated with abbreviated laparotomy or damage control. And basically through that simple algorithm, the results held up with respect to that almost all colon wounds could be repaired primarily, except for those that had destructive wounds and high-risk physiologic risk factors like massive blood transfusion and extensive medical problem. Next slide. More data from Sharp and colleagues, and then Manley looked at, and team looked at 2 decades of colon injuries, looking at what type ostomy was associated with the lowest risk. And the short version was that a loop ostomy was better tolerated, easier to close, in most instances, the right approach. Next slide. So in summary, the approach developed over 4 decades goes something like this: that all non-destructive colon wounds can be repaired primarily regardless of the risk or the patient. So in destructive colon wounds, healthy patients without massive blood loss can be treated with resection and anastomosis without fecal diversion, but patients with coexisting significant medical conditions or those requiring greater than 6 units of blood are treated with fecal diversion. And rectal injuries, I already stated, the approach is basically that's held up as well. And whenever possible, remove the ballistic fragment. Next slide. So to me, and I admit that I'm biased, but Dr. Fabian and colleagues transformed, along with the rest of the trauma community, but transformed and dramatically improved the operative management of colon and rectal trauma in a very systematic, structured, logical way. Next slide. And from a personal standpoint, whenever I came to Memphis, I would like to believe that I came as a well-trained surgeon, but I will just say that what's kind of become, in many ways, my life's work, I thought was kind of boring and uninteresting. I thought that, what is this trauma system stuff? I mean, please, but Dr. Fabian and the team at Memphis thought it was important and taught me about it. And really, because you thought it was important, I listened. That transformed my life. What you said about the trauma system is 100% correct. And it also was really clear and made clear that it's not just about the finance. It's about what's the right thing to do for the patient. That was a lesson that's articulated so clearly. So to me, I remember those days as if they were a few months ago, and I will always be forever grateful. And to me, the biggest legacy of this program, in spite of the importance of colon trauma, is a human-centered approach to trauma care. And that work will live on in through the work of all of the people in this room. Thank you very much. Next slide. There's question and answer. That's to keep us on track, I believe. Questions? Dr.
Hello.
Fabian.
I'd just like to say that, Ronnie, you were one of the best things that ever happened to the program. You've always been kind and very thoughtful. And I'm so proud of what you've done nationally. And you've made a huge impact on just the organization of trauma care over the country. And it's not by yelling and shouting, but just by your sheer persistence, which you have a much better approach than I do. But I'm so proud that you came here and you helped the program more than probably we helped you. Thank you.
Yeah, I'm really, really grateful. And I do see it differently, that I think I benefited from being here in ways that are hard to explain. I can tell you it's extremely improbable. It is like what I said, Jethro Bodine goes to Germany. But I'm really, really grateful. I'm not going to argue with your debate, but thank you for your kind words.
And always do remember that there's a 2-block limit.
There's a what?
2-block limit.
Oh, there's a 2-block limit. That's a dinner in Philadelphia. That's a dinner at Philadelphia. For those who don't know, I'm pretty much a teetotaler. I mean, not. By the way, it's unsafe at any dose, in case anybody wants to know. But that's what the data support. But so we went to dinner in Philadelphia, I think at the AAST, and we had some Bach. It's like some Bach thing. It's like a beer. Right? It's extra strong alcohol, and so we have this kind of hoity-toity waiter, and so. Martin and Dr. Fabian, they're ordering these Bachs, and after the second Bach is delivered, this waiter comes up and he goes, "I just have to let you know there is a 2-Bach limit." I was like, what is that? What is he talking about? There's a 2-Bach limit. You can imagine the response from other questions or comments? Okay, thank y'all. Oh, hold on. I do have one other thing. For those who are going to complain about me taking your picture and you're going to basically complain, I am the official photographer here, so I'm going to be taking your picture. So you need to just get used to it. Not that I wouldn't take it anyway, but.
Good morning. It's really difficult to follow those very, very impressive presentation, but I'll try. It is an honor to be standing here and talking about Dr. Fabian's contribution. In India, a teacher doesn't do justice to the term guru. Guru is used for somebody who is a friend, philosopher, and guide, a mentor. And Dr. Fabian, you have been that to me. Thank you. And it's a privilege to be standing here. I'll be talking about the contributions to liver trauma. The contribution list runs long, so I've focused on some of the ones that I feel are particularly important and that have made a particular difference. So to truly understand the breadth and depth of the contributions, what they achieved, I think it's important to get an idea, a bit of a perspective as to where liver trauma and its management was before Dr. Fabian came on the scene. So I'll start a little earlier. Liver injury traditionally has been associated with a very, very high morbidity and mortality. In the late 19th century and early 20th century, around 70% of the people suffering liver trauma died. primarily because of hemorrhage, both early and late. Dr. Kroos mentioned one of those cases. And major liver injuries often associated with other injuries in the abdomen. And lastly, there are infectious complications, usually delayed, that lead to mortality. But as early as the late 19th century, this gentleman collected 443 patients who were managed non-operatively. Now, this was in preparation for a manuscript we were doing, and I took this to Dr. Fabian. And he literally snatched it from me, looked at it, and says, if they didn't operate on them, how the hell did they know that they had a liver trauma at that time? But be that as it may, this is in the literature. So in terms of operative, these themes will come up again and again, how we have gone in circles. Beck published a history of liver surgery and quoted Burns from 1870 as saying that liver injuries should not be drained. In 1908, a British surgeon born in Australia, James Hogarth Pringle, did some experiments on dogs and actually showed that temporary occlusion of the hepatoduodenal ligament, taking blood to the liver, is reasonably well tolerated. And he used this to develop principles of operative management of liver injury. Compression of the hepatoduodenal ligament to temporarily stem the blood flow, also called Pringle maneuver. Suturing of the bleeding surface, packing for non-surgical bleeding. Even then, the mortality was close to 60%. In World War I, the mortality was about 61%. These principles were followed through almost the middle of the 20th century. In the interwar period, the mortality remains about. So the mortality remains stubbornly high. Then World War II comes along, and there is improved resuscitation, rapid evacuation, and refinements in technique. That leads to a mortality that drops to 27%. But the World War II surgeons felt that packing, as advocated by Pringle, was not good. It was associated with a high rate of complications. On the other hand, drains that had been said not to be used felt to be important, and they suggested a number of drains to be used. And at the end of World War II, the principles coming out for liver management was Pringle maneuver to stem the bleeding, suturing of the lacerations, preferably using a blunt needle, multiple Penrose drains, not just one drain, and no packing. In the 60s and 70s, there was some indulgence with operative drainage of the CBD using a T-tube. Now, it's interesting how some things just take a life of their own. This gentleman from Italy, he had published about 2 cases. And if you read the article, it is very, very sort of balanced. We have no idea if the T-tube insertion actually helped or not, but it is worthwhile considering. Well, rapidly, it became almost a 4th principle of operative surgery of the liver trauma, and a number of CBDs were probably harmed because the CBD can be very small in young people. And this went on till Dr. Lucas did his landmark studies to demonstrate that CBD drainage was actually higher. Another innovation that came along in 1975 was ligation of the artery that was really picked up by the Louisville group and published on by Dr. Flint. And in Dr. Richardson, when he was talking about 25 years of liver surgery, he himself acknowledged that maybe it had been used a little too much, and the people who need it are probably very, very few. So the principles, as Dr. Mays published in 1976 in the monograph on the current problems of surgery, were sewing ruptures, which could be dangerous, finger fracture could be valuable, arterial ligation is probably safe and could be used. And here they go from multiple drains to a bouquet of drains. I guess somebody was very poetic that you could actually excise the 12th rib and create a hole through which you can put multiple drains as a bouquet that lay over the liver. So this is where we are when Dr. Fabian comes on the picture. Suture liver fractures, as advocated by Pringle. Suturing is dangerous. Do not drain, advocated by Beck. Multiple or even a bouquet of drains should be used. Packing is good. Packing is bad. Non-operative management is a viable option. It fails almost always, so operative therapy should be pursued. So this is the mid-70s. One of the major problems of liver management is what do you do with that wide open cavity of a really bad injury where blood and bile leak? They lead to infectious complications and even hemophilia or hemorrhagic complications. So if you suture it, then also the closed cavity invariably becomes infected. Dr. Lamb and Stone published this in 1975 as an innovative technique of using a viable pedicled omental graft into this opened up liver. The technique was further refined, and Dr. Fabian and Stone published a series of 113 consecutive patients using this technique and demonstrated a mortality of 8% and acceptably low morbidity. Now, just to show the impact of all these, in all of these, I have mentioned how often they have been cited. This omental packing technique was further tested in one of the few randomized trials in the surgical history. Dr. Fabian, as was mentioned before, with the colon, it was one of the earliest randomized trials for liver trauma. Here, 482 consecutive operatively managed liver injuries were randomized to receive no drains or a drain, and the drains were randomized to be a closed suction drain or a sump drain. And the results, overall mortality was a very low 4.6%, and actually the liver-related mortality was 2.9%. And again, it goes to show what care was provided at Memphis. These are extremely impressive figures. In terms of drainage, what they showed was drainage is not mandatory for management of these liver injuries to prevent infections. And if a choice is made to put a drain, don't put a bouquet of drains or open drains. Closed suction drains are better than open or sump drains. In terms of hemostasis, 144 patients of these 482 required major techniques. Omental packing was utilized in 60% of these 144 patients requiring major techniques to stem hemorrhage. It had a mortality rate of 7% and an abscess rate of 8%. Again, this technique remains valuable even to the day, and I've certainly used it often. Second, gauze packing were used in 10%. All of these patients were in extremis, and it was life-saving for close to 70% of them because the mortality was 29% with an abscess rate of 30%. That has been cited over 200 times. In the 80s, AAST set out to develop organ injury scales for all major injuries. It's primarily done to offer a common language. We can always speak in grade 3 this or grade 2 that, and also to equalize injuries in terms of for research. And when the CT scans became more popular or became more available, grading could be done using the CT scan. Well, the question arose, what is the accuracy of that grading for liver injuries if performed solely for CT scans? This study from Memphis asked that question. It compared operative grading to CT grading. It discusses pros and cons of each modality. And what is, I think, more important is provides a methodology for objectively comparing modalities, the accuracy of each modality, the pros and cons. And this methodology subsequently went on to be utilized for other organ injury grading, and today is being utilized, this methodology, for non-trauma emergency general surgery conditions. Again, what does each lens of modality show you? This has been quoted over 150, cited over 150 times. A big change in management, as you all know, occurred in terms of liver injury management in the late 80s and early 90s. It really accelerated. That was the movement from operative to non-operative management. In the mid-90s, there were multiple reports. All were of small number, and majority of patients were of low-grade injuries, so you really were not comparing apples to apples. There was a single attempt at a randomized trial, but despite attempts at randomization, the groups were not well matched. So the Memphis group proceeded with a prospective study evaluating non-operative management. Unstable patients were directly taken to the operating room. All stable patients were non-operative managed, irrespective of grade seen on CT. As I tell my residents, oh my God, look at that CT is not an indication to go to the OR. And there was a comparison made with a matched operative historical cohort. The previous study of 482 patients, patients who would have qualified for non-operative management were extracted from that data set and compared. There were 136 consecutive liver injuries. 24 were unstable. They underwent surgery. Remaining 112 were stable, underwent non-operative management, of which 2 failed. 5 of these failures were liver-related. There were 100 successes, and these successes were compared with 84 matched historical operative controls from the prior study. And what they showed was that non-operatively managed patients had a lower rate of transfusion compared to their matched operative cohort and lower rate of abdominal complications. This study has been cited over 650 times. Following that pilot study, a more definitive study was undertaken. It was a retrospective cohort study comparing strategy. Now here it's important, even in the previous study, and many studies we see and presented at major organizations, there is an attempt at matching, whether you use propensity matching, whether you use regression analysis to extract what is significant. Here, Dr. Fabian and colleagues took a different approach. They looked at the entire cohort, so assessed a strategy of operatively managing patients or selectively operatively managing patients, but the comparisons were not done between patient groups. The patients comparisons were done across the entire cohorts. From 1995 to 1990 was the operative cohort of 168 patients. 93, 94 was the study I just presented, non-operative managed 1, the pilot study, and 94 to 98 with non-operative management 2, the study at Memphis. It became standard of care for managing all stable patients non-operatively. And as I mentioned, the outcomes were compared between entire cohorts. And the question we were asking is, what is the overall impact of the shift from operative to non-operative management on the outcome of patients with blunt hepatic injury? Now, here's what we found. So in the operative cohort, 100% were operated. In the non-operative 1 cohort, the pilot study, about 26% were operated. In the non-op 2 definitive study, about 20% were operated. The blood transfusions were significantly lower in the non-operative 1 and non-operative 2, despite, as you see, only 20% being operated upon. The abscess rate was significantly lower. The length of stay was significantly lower. But interestingly, the liver-related mortality, just under 5%, did not change across the 3 cohorts. So it seems that the mortality, as for the mortality part, we had hit a plateau, but these strategies really help avoid surgery, avoid blood transfusion, and lower rate of complications and lower length of stay. This study has been quoted over 450 times. The other thing the study aimed to do was, what about the people who fail? Is it possible that the people who fail actually were harmed? Had they been operated on earlier, they may have done better. It's a counterfactual. It's almost difficult or impossible to answer with complete certainty, but using some innovative analyses and comparisons, what was shown was that, of course, as the grade of liver injury increases, the failure rate increases, and the proportion of failures that are liver-related increases. But also, that failure of non-operative management did not adversely affect outcomes of the patients that failed non-operative management. So the fundamental shift, this was presented at the Southern Surgical Association in Roanoke, where Dr. Britt commented that while this is not the first nail in the coffin of operative management of solid organ injuries, I do believe that the medical historians will ultimately assess this as the biggest nail. Another first at that time was that this was probably the first time that at a major surgical organization, a study was presented using PowerPoint. Dr. Fabian was an early adopter, like so many other things, of using PowerPoint. And he asked the association for permission to use it, PowerPoint. And the association says, go ahead, be our guest. But we cannot promise a projector that will accept the PowerPoint input. So it was, I think, about this size projector, big, bulky, heavy. And Dr. Fabian carried it as his hand luggage. He brought his own projector and presented using PowerPoint. Did go in the hand luggage, yes. So now, last few minutes, I'd like to spend on a personal note. A lot of people have mentioned about what education they got. Different people take away different memories. One of mine was exactly what Dr. Cross has mentioned. He had the computer, he had the modem. So at the time of abstract, I was called to the Dr. Cross's office. We were completing the abstract, and yes, it was the last day. And I find these two people, both professors, both I respect a lot, arguing, bitterly arguing, at each other's throat almost, arguing about every phraseology, every word, every comma to make it fit in that abstract box. And from that, I really took this to which has served me well, as to how to be able to distill the message that you want to convey it effectively using the fewest possible words. Thank you, Dr. Fabian, Dr. Cross. The second element is this. It was always on the last day, always at the last minute, and the fellows would have to make a trip to Memphis airport to put it in the night box of the FedEx to go overnight. So half the stuff in this world would not get done. Yes, sir, still TFA. The other element has also been mentioned is how we were welcome at Denise and Tim's house. I had just joined as a fellow, and Ramona called me and said, you are invited to Denise's gumbo party. I said, oh, okay, fine. Thank you. First thing that went through my mind, what is gumbo? Is it a fancy dress I will have to wear? So that time, there being no Google, I actually had to go to the library, find a dictionary, and found that this is. And to my simple mind, gumbo equals soup. Dr. Cross, simpleton is good. So then I go home, and my mom says, Denise Fabian called. I said, oh, okay. What about? Is something wrong? She said, no. She's invited us to a gumbo party. I said, oh, really? The whole family? That's very nice. And while I'm sort of thinking, that's very nice. And my mom says, what is gumbo? Is it a dance of some sort that we will have to do? At 94 and 89, my parents have forgotten a lot, but they still remember your kind invite and welcome to your house. Thank you. So in summary, through rigorous techniques and innovative research, Dr. Fabian and colleagues have shown innovative surgical techniques like omental packing, defined methodologies like objectively comparing grading modalities, comparing strategies of management, debunked long-held biases like drainage is essential in surgical management of liver injury, and provided a scientific basis for controversial practices like packing can be life-saving and non-operative management is actually superior. Thank you all. Yes. I'm not going to say anything else. Well, no, I did not bring that up. Yes, in these series, angioembolization was used quite frequently for the non-operative management, but as you well know, it has gone down. And what the exact role is, particularly for liver, is still being defined. Thank you all.
Short breaks good. They have contributed a couple of photos. Not a bit.